My name is Rashmi Halker Singh, and I'm the online and social media editor for the Headache Journal. It is my absolute pleasure today to be joined by two of our award-winning authors of the Members' Choice Award of the 2022 manuscript, Management of Primary Headaches During Pregnancy, Postpartum, and Breastfeeding, a Systematic Review. So welcome to Doctors Julie Roth and Ian Saldanha. Thank you so much for your publication. It was so exciting to read this manuscript.
Thank you for having us.
Yeah, thank you for having us, Dr. Singh.
So this systematic review has been really exciting to read. And as you can see from the response from our readership, it's been really a well-needed manuscript as well, because we really don't have a lot of guidance in how to help our patients who are pregnant in terms of managing headache. And I think this paper has been really helpful and impactful in that sense, just because we have a little bit of, evidence-based medicine that can help guide that conversation. So I think it's been really important. I think would be helpful for our readers to better understand what exactly was guiding the systematic review. I read that this was done under the Agency for Healthcare Research and Quality Evidence-Based Practice Center program. What exactly is that?
Yeah, so I'm here at the Brown University Evidence-Based Practice Center, and Dr. Roth is also here at Brown. We are one of 9 evidence-based practice centers that are in the US. And a lot of our work is funded by the Agency for Healthcare Research and Quality. Now, the Agency for Healthcare Research and Quality, or AHRQ, is one of the agencies that falls under the US Department of Health and Human Services. Other agencies listeners may be familiar with the NIH, the CDC, etc. Now, under this agency, they have a program that's known as the Effective Healthcare Program, through which they fund us as contractors to do systematic reviews. And that's how we got involved in doing this work. And that was the umbrella under which we did it.
Awesome. So tell me about your project and what were your findings?
Yeah, sure. So our project was on the management of primary headaches in pregnancy. As you alluded to, Dr. Singh, early in this conversation, there hasn't been or hadn't been before this a summary of the evidence on this topic in pregnancy. There were 4 primary headache conditions that were covered as part of this work: migraine, tension type headache, cluster headache, and trigeminal autonomous cephalgia, so TACs. And this work was conducted to inform a guideline that has recently been issued now by the agency by the American College of Obstetrics and Gynecology. And that guideline fills a gap because the existing guidelines from the College on Management of Pregnancy did not address headaches, and existing guidelines from the American Headache Society had not addressed pregnancy. So this is intended to fill that gap. So we, as part of this systematic review, addressed pharmacologic as well as non-pharmacologic interventions to prevent or treat primary headaches in women who are pregnant or attempting to become pregnant, or postpartum, or breastfeeding. So we did that systematic review following standard methodology for doing systematic reviews. Detailed methods are in the paper, of course. I'll summarize in brief some of our main findings for this. So in total, we found about 8,000 records in our search. We ended up including 16 studies that addressed the topic, but we also looked at existing systematic reviews because we wanted to also not just look at studies that have addressed this question in women who are pregnant or postpartum or breastfeeding and have primary headache, but also a lot of these drugs and treatments that are also used outside of primary headaches, like for epilepsy and for other conditions. So we wanted to look at the body of evidence, even when those drugs are used for those non-headache indications. So we looked at existing systematic reviews that have looked at the harms of those treatments. So altogether, looking at our primary direct evidence in which we looked at the primary studies, as well as those other systematic reviews, For the non-pharmacologic interventions, we really did not find enough evidence to make any conclusions about the non-pharm interventions. In terms of the pharmacologic interventions or the drugs, we found that for prevention, we were only really able to make conclusions about the harms. A range of interventions, categories of drugs may be associated with fetal or child adverse effects like anti-epileptics, venlafaxine, tricyclic antidepressants, benzodiazepines, beta blockers, prednisolone, and oral magnesium. But on the other hand, calcium channel blockers and antihistamines may not be associated with fetal or child adverse effects. In terms of treatments for primary headaches, the one conclusion that we were able to make based on the evidence was for patients with migraine or tension headache, that the combination of metoclopramide and diphenhydramine may be more effective than codeine for that condition. And then for the harms, on the harm side of things, triptans as a class may not be associated with fetal or child adverse effects, but on the other hand, a range of classes may be associated with those harms, like acetaminophen, prednisolone, indomethacin, ondansetron, antipsychotics, and IV magnesium. And finally, low-dose aspirin may not be associated with those harms when used in this population. So that's sort of in brief, or somewhat brief, the conclusions that we were able to make as part of this systematic review.
So that's a wealth of information that you were able to uncover from this data set. Was any of this surprising to either of you?
Maybe I'll deflect that to Dr. Roth.
Yeah, I mean, to me, I see pregnant patients with neurological conditions as a large part of my practice, and some of the casual advice that we spend a lot of time giving our patients, like, oh, just take acetaminophen, and then for that to come out in recent years, seeing articles about potential harm from acetaminophen, and then for that to come out in our systematic review, I would say that was one of the more surprising findings, things that we've taken for granted as not having so much harm. And then for the triptans actually to come out, that it may be okay to continue your triptan medication during pregnancy. I think those were some of the surprising findings. And then there were some findings that were not so surprising to me, like there's really not enough data out there in pregnancy. I think we all know that. And this was just kind of really hit home that we really need more research in this area. You know, when we were doing our abstract reviewing process, and we kept throwing out these studies that are, these papers that are great papers, but they were lit reviews. They were really not appropriate for a systematic review. It's amazing how much advice we give based on expert opinion in clinical practice that's not necessarily based on evidence. And expert advice is great, but I think in this area, that's something that there's a real need to learn more about pregnancy.
So your manuscript has definitely changed my clinical practice. And before I share that, I'm curious to hear how it's changed yours.
Sure. So I do have patients, the acetaminophen. I mean, there is some signal. I'm not throwing out acetaminophen altogether, but when patients are being told, well, you know, I just take acetaminophen every day, I said, you know, if it's not working, please don't take it, because it actually might be causing harm. And if your headaches aren't getting better, there's no reason to be taking something that that might not be improving and might actually be potentially causing harm. I think it has given many of my patients permission to take their sumatriptan, which they were afraid to take during their pregnancy. I'm trying to think what else. I have actually used calcium channel blockers, which was not necessarily part of my initial array of go-to preventatives. And then one thing, you know, we used to casually recommend metoclopramide and with or without diphenhydramine. But it's nice to see that there's actually evidence for that. And I can more confidently tell my patients that there is, it may not be the strongest evidence, but we do have some evidence that from a treatment effect standpoint. One other way that it's changed my practice is that I have patients who come to me for a variety of reasons, and some of them may have comorbid depression or anxiety. And they might be taking venlafaxine, they might be taking some of these other medications for other indications. And we did have signal based on our review of these other systematic reviews. So that actually opens up the conversation about some of these other areas and comorbidities.
Yeah,
I'm now interested to know about your practice, of course.
Yeah, absolutely. So as you know, I'm a headache medicine clinician, just like you. I see a lot of people who have migraine, many of whom are contemplating pregnancy or might be pregnant themselves. And this conversation comes up a lot about how to treat migraine during pregnancy. And your manuscript has helped to inform that conversation significantly because we finally have some really good evidence that can help that conversation. And we used to think about harms and should we not treat migraine, and should we really rely on non-pharmacologic treatments, as first line. And you showed us that, well, maybe they're not as effective, and maybe it's actually okay to use sumatriptan. So myself and some other colleagues published a few years ago. It was a member survey from members of the American Headache Society about what they're doing in their own clinical practice in terms of guiding and counseling pregnant people for treatment of migraine. And I was curious to see about what they're doing in terms of triptans. I actually went back and looked at that manuscript. And you'll be interested to know that everybody who answered that survey was kind of across the board. So looking at triptans, it was actually very split. So about a quarter of respondents said, oh, they would never use it. Some people said they were kind of uncomfortable. Some people said they were kind of okay. And some people said they were definitely okay. So it was very split on that question. And your data suggested that the evidence is probably that it's okay to use and that there's probably no harm, which is consistent with the registry data as well. And when we think about having a patient-centric conversation and giving them the best evidence to make decisions, I use that in my conversation with my patient, because we also know that there's harms to not treating migraine during pregnancy, right? There's the pain and disability associated with the attack, as well as lost work, as well as, the dehydration, the need to use acute care, all of these things that can happen, secondary problems that can result from untreated migraine as well. And now we can counsel them that we have a systematic review as well as other data that suggests it's probably okay, as well as everything else we know about the natural course of migraine during pregnancy that occurs for most people. So I use that in my counseling. And it's been really helpful to add to that whole patient-centric approach to counseling that we like to use. So that's been great. Anything else you want to share with our viewers?
I would just like to say that what both of you have just said, it is quite fulfilling for us who, I don't practice clinically. I do a lot of systematic reviews. This is why we do it. We want to make sure that the most up-to-date and the body of evidence is brought to bear on clinical decision making. So it is fulfilling to hear that, and grateful for the award as well. So.
Yes. As am I. This has been a great collaboration. We worked, another clinician that I closely collaborate with, Dr. Ken Chen, worked on this project as well, and a team from the School of Public Health under Dr. Saldanha. And it was really a rewarding process, because a lot of our conversations were, well, what do you do clinically? Well, what is what does the evidence show? And that back and forth, I think I've actually told a lot of people, it was so rewarding to have that conversation. And even that process of putting this together was a really rewarding experience. The other kind of final thought that I have is just that the sparsity, that what we're looking at, it's so important that if you're practicing and you're seeing patients all with the same disorder or all in the same category, like a lot of pregnant patients, and you're finding something, maybe think about publishing or researching that. And even if you don't think of yourself as a research person, it might be important for the general public. And this is where it comes out, because when you find okay, maybe many people gravitate towards occipital nerve block, for example, and we didn't find enough data out there. Nobody was publishing their data. If there had been a randomized controlled trial that fit our criteria, but there hadn't been. So the lack of data doesn't mean something doesn't work. It just means there's a lack of data. So I can imagine us revisiting this topic down the line when maybe there's more data, but I just want to really put a push out there that if you have an idea, to maybe please get it out there, because we really do want to know what works. And this is how we figure it out.
And just like to add to that, from a methodological perspective, yes, it may not always be possible to conduct those big, large randomized trials that we love to see and love to make our decisions based on. But even when conducting non-randomized studies, we had to exclude a set of studies, unfortunately, that didn't quite address potential differences between study groups in terms of confounding and other factors. Or we had to even if we included them, we had to downweight the strength of the evidence, at least which means the strength of our conclusions, because of some of those limitations. And we get into some of that in the discussion, and we make some suggestions for those doing that future research that we need.
Well, these are all excellent points. Congratulations again on your award, and I look forward to more work from both of you.
Thank you so much. Thank you, Douglas. Thank you for having us.